So this is a nice little summary of the article. I'm not a big I don't love to read big long articles. So these people, Physio Network, I've sort of spooked them a few times on these sort of recordings before, but they do a lovely way that they just summarize the key points, and it's easy to read, and it's just easier when you're not a big reader yourself. So this study that they looked at sort of changing the ways, and they spoke about changing the ways that we view knee away. So their three sort of main sort of points that they were talking about was sort of changing the message, because I guess knee OA there's a lot of sort of connotations with it, negative connotations, and some common myths around it. But it's also a very common condition to have. So changing the message from knee pain is caused by damaged structures within the knee towards knee OA related pain is a modifiable symptom that is related to the sensitized knee structures. So it's the damaged structure does not correlate to the pain, and the pain is definitely modifiable. Does anyone have sort of any thoughts or any sort of comments around that first point?
Hey, Avi, can I bring you into this? Because we saw a few people like this in your time here, didn't we?
Yeah.
What are your thoughts about what an X-ray or what an MRI might say versus function in not only your experience here, but what you've seen in the US, and then maybe outcomes for the patient as a result?
I find that there's not generally a huge correlation between MRI or like imaging results versus symptoms and functional abilities. And I think people tend to perseverate on what their imaging findings are, and it usually doesn't lead them to like a good mental space, and they think that they can't do certain things even when there's might not even be any symptoms.
Yeah, absolutely. Can you remember that client we saw here that we were seeing twice a week who had everything shot? We just won't give it away, but I'm sure you know who we're talking about. Who thought he needed surgery for everything. What do you think you would have done if you had got to him early? Because I think by the time he got to us, he was just convinced everything was done. What do you think early intervention looks like for people? Maybe if they just have some mild knee OA and discomfort, in terms of education and how you would sort of pre-frame it for them to give them hopefully a successful outcome.
I think it's kind of important to educate them on how imaging findings don't necessarily correlate to their functional outcomes and their pain level, and that everything tends to be pretty modifiable in most cases, and there's more to it than just what an image might say. And people that say they're bone on bone tend to not really know too much about what they're talking about. I've realized a lot. I don't know if that's like a generational thing too, but I hear like my parents saying that all the time. Like, I'm bone on bone. Okay, cool. But
I think, yeah, I think the perception around bone on bone is just, crazy. And then when it's in your head, it's done. And I remember how effective are you got your RV on and just started just telling him off, saying you're not allowed to say that anymore. I think we should have made him have a bone on bone jar or something. Every time he said that, he puts $1 in. But back to your point, because it's so important, particularly in the US, I think, where so many people want that quick outcome, don't they? They would definitely have a pill if it could take away the pain. It must be even harder to educate sometimes. It is hard enough for us. So, really just remember where you've come on with these sort of clients, and just that education, doubling down on things so important. Nat, do you have anything to add?
I was just gonna talk about the verbiage that you use and how you explain what's going on to your patient is very important as to how they perceive their pain as well. And
Cool. I think pain perception is very, very important. And that's why we double down here on education around that. Not talking to them, but talking with the client, and something I highly suggest. There is no magic formula. Yeah, really be aware of that. Hey, Riley, the non-physio in here, do you have anything to add to what we've just said?
Yeah, kind of just like what Nat said. Like, I think it was 2 tutorials ago we spoke about like how you believe things is how you portray your beliefs about things is what's going to affect the clients the most. So I think that's important here, because you have to kind of like completely restructure their mindset about things. So yeah, I don't know if that makes sense, but that's where I'm coming from.
Yeah, I think to wrap that up nicely, you've said something really nice there, and doubling down on your belief and your perception that no, I'm very confident that from what I'm seeing, there is some wear and tear, and bone on bone, acknowledge it, but we can help you. The research shows with structured exercises, we can get you stronger, and as we get you more strong, as a result of that, your pain symptoms will come down. But you have to commit to that 8 to 12 weeks of structured exercise or things like that. But your belief and your passion around that, I think, is really important. But good, guys, some really good ideas. Push forward, Jack. If there's anything, unless you have something to add.
And I think that's a good one that you said. I've like acknowledging their beliefs. So you don't want to throw it away just yet, but really sort of chip away at changing those. You can't just do it in one session, but chip it away. Moving on to their next point. So I guess the change in the treatment from, gone with the day was the first line of treatment was straight into the operating table. Now where there is great evidence out there to suggest that your first line of care or your first go-to treatment is educating the patient about how best to self-manage the condition, what they can do to modify their symptoms, and how best to change what they're going through, as well as structured progressive strengthening and exercise. Sort of like you can have the second line treatment with the passive therapies, that they say the biomechanical aids and the pharmacological therapies, but surgery should be the last line of treatment if exercise in those first line of treatment has not worked over a longer period of time. What do we think with that one, guys? We all in agreement?
Yeah. I just can't believe how quickly a lot of surgeons still push for the arthroscopic procedures. It's crazy. So be wary if anyone is being offered that as to why. Can anyone, and just speak out, think about just talking about surgical implications, when you would think that surgery is a good outcome before physio intervention, conservative? Can anyone think of a reason why in terms of knees? No?
What was the question?
The question is, where surgical, it's late in the States, thank you for staying up, where surgical intervention would be more appropriate than conservative physio treatment in a chronic knee?
Maybe if the patient had a lot of comorbidities that made it difficult for them to like exercise. And
what?
I don't know, that's just the idea that
okay. Thank you for putting that out there. I still don't know why you'd have knee surgery because of it, though. That's all I question. You know what I mean, Nat? Like, why would you say have an arthroscopic procedure if they're, maybe morbidly obese?
Sorry, why would you tell them to?
Yeah, why would we still not try something conservative before surgery? That's what this point's sort of throwing out there. I can think about, actually, before I talk about Avi, can you think of an example where you would go surgery before conservative in this sort of a population?
Not necessarily for like chronic, if it was like an acute traumatic something.
Absolutely, yeah. Acute traumatic. Well, you stole my lingo. I can think about potentially, even meniscectomies, the most recent research is the majority of them, are no better. In fact, a lot of them are worse than if you don't have any, than doing conservative management. But if there's some sort of bucket handle tear that's locking and, and it's not getting any better, potentially. There's an interesting example, actually. Hey, Avi, do you remember how my sister did her ACL recently while you were there?
Mm-hmm.
Yeah, so she wasn't getting full extension still, and she's 9 months post. And she saw the surgeon and had an MRI. Can you guess what the MRI said? What came up on the MRI?
I don't know.
Have you heard of a cyclops lesion?
No.
No. Jack, do you want to explain this is an interesting one, and look this up after. Jack, do you want to tell them what a cyclops lesion is, because we spoke about it recently?
Yeah. Correct me if I'm wrong. It's like a little bit of bone sort of chipped away, and it's preventing that full extension.
Correct. So literally, for what it's worth, it wasn't, the bone on bone wasn't sitting correctly, and it's literally caused a functional deficit which doesn't allow for full extension. So she just messaged me an hour ago and said that the surgeons recommended she comes back in for a vision to deal with that cyclops lesion. So that's interesting. That's an example of where, a bit more traumatic, but I just thought, wow, that's interesting, to get that full extension as a tandem.
Yeah. Wow.
So look up what a cyclops lesion is after, because, that's poor thing. 9 months post, had a pretty good rehab, and to have to go through surgery again. And, she called me crying, as she always does, poor thing. Very empathetic brother I am. Oh my goodness, this is recording too. Whoops. My bad.
Your sister's a physio, right?
Yeah. Beck's a physio as well. Correct. A must physio like me. So like us, right? Like all of us. So yeah, except Riley. Sorry, Riley. Yeah. So just something to be aware of. I guess the summary, guys, is when you've got a chronic knee in front of you, surgery is not the first point of call. I can't think of an example where it would be. So just keep that in mind. And I know it might make sense, but your belief around being passionate and saying, no, this is the right point of call, this is what we should be doing. Get your client to believe you and buy into it. It's so important, because it's super, super important. Keep going, Joe.
Yeah, and then coming to the last point, which is super important as well, putting the patient in charge of their treatment plan by increasing their self-efficacy and promoting that self-management of their condition. So if they feel confident and in control with their program or their rehab, and they're able to do all the other stuff at home, away from the clinic or away from you, they're going to be having so much more successful outcomes. And so I guess this study wasn't really based on a clinical trial or anything like that, but it's brought in all the research together, and then trying to promote that change of how we think about OA and how we treat OA. And just with us, we're sort of, if I can just bear with me. There we go. Can you all see my screen still?
Yeah, look at all those tabs.
Yeah,
you'd like
you'd like that, wouldn't you, Avi?
There's a few up there.
By the way, look at this, Avi. Look at this bed.
It's probably about half as
one
many
pillow cover. That's it. That's all we have here. Yeah.
Good job, proud of
you. Stripped clean, by the way. Done. Anyway, keep going. Just
proud of you.
Point that out. Yeah.
So this GLAD program is a program where physios sort of, I guess, they do have to get accredited to be a GLAD physio, whatever that means. But basically, it is just a designated program around treating knee OA, and its structure is with an initial assessment with 2 main short outcome measures taken, 30-second chair stand test and the 40-meter walk test. And then following that, there's 2 group education sessions, which I think is super important and I think it's pretty, super important in a program like this that requires, with NEOA having those negative connotations and those, a lot of myths surrounding it. 2 big sort of 60 to 90-minute education sessions delivered before the program starts is key, just to educating the people out there that have NEOA about their condition and what they can do to self-manage and how best to treatment and what the program will look like. And then from there, it's a twice weekly 60-minute group exercise session, just all designed about strengthening the knee and the hip. And then the follow-up assessment at 3 months, where the 2 outcome measures are measured again, and hopefully we'll see big improvements in that area in function and pain levels. Does anyone have any sort of questions with or like any comments with that?
I just want to get the Americans in USA. How would you implement? This is just more a philosophical one because, you know what? Let's first things first. What do you both think about that structure? And then I wanted to think about how could you implement it within the health system you have? Because that's a problem we would have as well with that. So yeah, firstly, what do you think about that structure for NEOA? Avi, do you want to go first?
Sure.
Yeah.
I like it. I think it's nice that they're doing lots of education and at the start, so they're already kind of be in a good frame of mind before actually getting to all the exercise and whatnot. It looks like they're using outcome measures, which is good. The only thing, I don't really know how this would be implemented here, just based on how everything is paid for, and most people with OA are older, so they're probably going to be on Medicare, and Medicare doesn't cover a lot of that stuff, kind of. I don't know about the group session. I mean, I think it's a good idea. I'm not really sure. I don't know. Insurance is really complicated here.
As I'm learning more and more about it, as I follow what's happening in your country. Nat, do you have anything to add? Because I'd love to help both of you come up with a way in which potentially it can be implemented, but I just don't see it with the system you have. But anyway, Nat, yeah, any thoughts?
So this program, was it researched as well?
Yeah, Jack, you want to talk?
Yeah, so might be a bit slow this internet. A few people on it. Yeah, so they do have sort of, I think 5 sort of trials that this GLAD association did. And so yeah, so this sort of structure and program is trialed, and I think it's a big thing over here in Australia. I think it started in the Scandinavian country, but this is the GLAD Australia website.
Yeah,
so I mean, personally, from my experience in the US, I haven't seen group exercise sessions for this particular type of, for example, for OA. But I guess if they pushed for it enough and were able to prove that there's research back behind it, then you could maybe incorporate it in your hospital, as an additional free service, or I don't know, perhaps something like that.
I think they kind of changed it for skilled nursing facilities. They changed the payment model, so I think that they can do group exercise now. I don't really know though, because when I was in the SNF, it was before they changed the payments stuff. So I think it also just depends what setting you're in. I mean, I think like an outpatient
Yeah.
for like what I've done is pretty much all of those components, just more like individualized and not necessarily a group. And like you don't have a 60 to 90 minute education session. You have to just build in the education throughout your treatment.
Is there a reason why they found that a group exercise was useful for this?
Yeah, Jack.
Like, is it just out of convenience, or did they actually find that it was helpful, more helpful than one-on-one?
I couldn't tell you, but I'm just assuming with the group exercise class that part of a group and they're sort of what's the word? I guess they're with all the sort of benefits of group exercise classes, they're that increase adherence because they're relying on other people, they're using other people, they're catching up with possibly friends, or as well as I can't think of the right word, not reliant, but
I think it's just more efficient.
Yeah, efficient on part of our part as well. Yeah.
But I want to go back to what Avi said, because I think that's where I want to get to, because it's not practical for us to run GLAD right now. We just don't have the space, but we do like the program. So coming back to what you said, Avi, so this was the internship before mine, I gather. Were you doing stuff like that in a one-on-one? Do you want to just talk about maybe just an ideal client journey with NEOA and how you embedded those principles into their client journey?
Oh man, I'm trying to think.
Taking you back.
I know. Well, I saw a lot of people that were like post total knee replacements.
Got it. Yeah.
A bunch of people that were like combo hip and knee OA. But yeah, I mean, we would always do like an outcome measure with them at the beginning and do like a progress note in the middle and at the end for discharge. And a lot of times it's more just about like functional abilities rather than like pain. So you try not to focus on the pain so much, and you try to like educate on how to manage flare-ups, because it is a chronic condition. Like their cartilage is not just gonna magically like reappear, so it's not gonna like go away. But there are ways to like prevent surgery, which I think is, I don't know, we would always just try to like educate on that throughout sessions and in between sets. But yeah, does that answer the question?
Yeah.
Sorry, I'm like kind of tired.
No, hey, that actually answered it really well. I was just like, hey, do you want to come back here? We miss you, because that's the stuff that you helped embed us in here. Remember those little progress notes templates that you made us? Do you remember how our notes are like 20 times better than when you? That
still.
Yeah, that is the epitome. And for you, Nat, I guess, that's the epitome of what you're trying to do. If you can be more objective, if you can educate, you can embed the program into what people you see and pre-frame to get good outcomes. I think that's really important. So we will wrap this up soon, but no, thank you. I think for me, I wanted us all to take something away from it. And I think that the big takeaway for me is that you can do this in a one-to-one setting if you have the right structure around it, which is outcome measures, which is continual education and pre-framing how to get better. So no, you did well there, Avi, even though you're tired. Well done. Thank you. Excellent. Nat, do you have anything to add? Just with the implementation side of things? You don't have to. It's cool.
I kind of got lost in sorry. There was a lot of discussion there, so I kind of got.
What did you take from it, Nat? That's okay. We always want to come back to the simple.
Yeah, I think every individual has their own goals, and you have to be very observant of that and not try to really like push what you think is right for them necessarily. And like maybe for some people this type of group exercise is great versus for others it may not have as great of an impact.
Yeah, I really like that. The individual, you've got to treat the person in front of you, not the condition. And I think that's a really, really good point, Nat. Yeah, for sure.
Well,
I just hope you
identifying motivating factors. So like understanding what motivates the individual to want to like get stronger and
so going more than just their pain, their why, shall we say. I said more than just their pain, maybe their why, their ability to play with their grandkids, to play golf, to do things like that. Yeah,
for sure.
It's all embedded there. Yeah, great point. Riley, I've just kept you quiet. Do you have anything to add before we wrap this part up?
Yeah, probably just like what Nat said, like what you said as well. I treat the client, don't treat the condition. So even though it's all there that you don't need surgery, if they believe they do need surgery, then don't be like, no, you're wrong, you don't need surgery, none of that. You have to educate them and like keep open-minded, make them open-minded to new things and stuff like that, which can sometimes be a bit hard.
Yeah, no, I love it. Cool. All right, some really good points there. Cool. Jack, you want to, I think we're towards the end, mate. Do you want to wrap this up?
No, I think we're good. Yeah, that's sort of all I really wanted to get out of today's, and
No, thank you all for your input. I guess to summarize, then I'd love to hear your top takeaway from that little discussion we had with that article is that there are different protocols, out there to treat knee OA, but it's not a one size fits all. It is a long-standing process that requires continual education, that requires reinforcement, of exercise, and involves working with the client to achieve good outcomes. The LAD program, I remember we were talking about this a bit about this argument. We sort of, when you were here, but we sort of like, we'll get back to it. Yeah. We actually read the article now.
Okay.
We sort of do implement it, but we can't do the official stuff because we don't actually have the facilities to. So how do you embed those principles in what you do? It's going back to what you know so well. So yeah, what's your top takeaway from that article to wrap up? Jack, you want to go first to let everyone have a think about it while you go into it?
Yeah, I just think like the importance of education. It is just sort of, there's everyone. If you whenever you get someone with knee OA, the first thing is always bone. It's the worst thing ever. It just sort of like having that education at the start and then chipping away at sort of changing their beliefs around their condition is just so important. That's going to, in the long run, going to help with adherence and how successful their treatment is.
Yeah, definitely. Avi, what was your top takeaway?
Jack kind of stole my thunder there. I was going to go with patient education. I think just like reframing their mindset and kind of figuring out your patient's baseline starting point and what their beliefs are and working with them to maybe change their beliefs towards more conservative management.
And if there's, Avi, just particularly for you, because I was talking to Jack about this last week, if there's one thing I've just picked up over the last few weeks as we've sort of stopped treating face-to-face, but now we are again, that our belief is so important to help their belief. If we're just like, maybe exercise will work. Like I always come back to I always enjoyed watching when used to kick some of our clients' butts. I could see like the raw passion in wanting them to get better, which is a real good quality you had. And I was like, that's really right. You really believe what you're doing is going to help. And that is so important because if we're half-assed in our own beliefs, it's never going to relate to the clients as well. So yeah, thanks you for that. Nat, have you got something? Yeah, what was your top takeaway?
I thought it was a nice article because it wasn't too long like a lot of other articles that I've read. And I like the examples of the clinical scenarios that they gave and kind of like how you should focus, what you should focus on with each example. I don't know if I, like in the article, well, I like to run and stuff. And Recently I read that because there's such a huge misconception about running contributing to osteoarthritis, like
Ooh,
like
yeah.
that it's bad for it. And yeah, I just read something recently. I was trying to look for it while we were chatting to share with you guys, but that they found that there isn't really, it's not actually bad for our knee OA. And like I think this article kind of like touches upon like just like how important like movement actually is for it, and understanding load, and really trying to find ways to help educate the person so that they can manage what's going on.
Yeah, no, thank you. I know it's a similar takeaway, but no, appreciate it. And there's so much we can do without our hands. I think that's really, really important. And how we pre-frame and set people up to help them, I think, is so important. Awesome. Riley, what was your top takeaway?
Yeah, well, everyone kind of has it all covered, what I was going to say, but yeah, just educating each person differently is important, because obviously each person has different beliefs, and just believing what you tell them, because as you said, Ives, if you're like, oh, it might work, they're going to be like, well, will it or not? But if you're like, yes, this will work, they're more likely to take that on board and be, a part of it.
No, what a great way to sum up. I hope we can all, take action from it as well. Obviously, we got Avi starting for the boards. Now, are you treating at the moment, by the way? Are you practicing right now?
No, I'm still dealing with the board here, and I have to pass we have like a ethics exam.
Oh, yeah. So not yet.
And I need to pass that one. So once that's done, then I need to find a placement. And
oh my God, what? You
so
keep
it's
going.
kind of tricky. Yeah, it's kind of tricky because you know how Avi, she had to cut her internship short, and basically I'm not tied down to a school, but I basically need to find a clinical place. It's like finding a placement on my own. So that's the last thing I need to do.
Well, good luck. Well, good luck with that.
Hopefully soon later I will be practicing.
I guess I hope it just plants a seed that when you see your first knee OA patient, you have a framework which you can work with. But that's it from us. Thank you for joining us. Avi, thank you for this idea. Journal Club was your idea. This is the first online journal club, so it's so good to particularly have you a part of it. And we'll be doing same times every week. It seems to be the best for you Americans. So if you ever want, if you want to jump on board, Jack and I and Riley will always be discussing something, maybe doing a tutorial. But thank you all for jumping on board. I'll stop pressing record.